Hello, this lecture is on myocardial infarction, or as the layman's term would be, a heart attack. This lecture will cover or try to define what a myocardial infarction is, look at the clinical symptoms, any clinical investigations that would be carried out in helping the diagnosis, acute management, complications, and then long-term management. So if we have a look at a definition, then it comes under the auspices of an acute coronary syndrome, and an acute coronary syndrome also includes unstable angina, and then it would also include non-ST elevated myocardial infarctions and ST elevated myocardial infarctions. And really, these acute coronary syndromes really are a group of clinical symptoms compatible with acute myocardial ischemia. If we then look on, if we look at the myocardial infarction term, it's used to describe necrosis of the myocardium associated with severe ischemia. It's most commonly caused by acute occlusion of the coronary arteries, by the rupture of an atherosclerotic plaque, and the formation of a thrombus, and that would be classed as a regional MI. Diffuse MI can occur as a result of hypotension or where there is a reduced general flow within the coronary arteries. So what are the clinical symptoms of acute myocardial infarction? Well, the main complaint is chest pain. It can be severe in nature and lasting at least 30 minutes. The pain does not respond to sublingual GTN. If we remember from our lecture on angina, then normally sublingual GTN will reduce the symptoms, and the symptoms only last between 1 and 5 minutes. The pain can be described as tight crushing pain, which may radiate down the left arm, throat and jaw. The pain in the left arm is thought to be caused by the nerve supply to the heart and the left arm originating from the same spinal segment. There would also be associated sweating, breathlessness and nausea. In elderly patients, however, then they have relatively little pain but may present with features of left ventricular failure or severe breathlessness. So past medical history would also need to be considered when somebody's presenting with chest pain. So we would look for risk factors of coronary artery disease or ischemic heart disease. So looking at what those risk factors are of age, older than 45 in men, 45 years in men, postmenopausal women are at increased risk. If we're looking at cholesterol profile, then patients with high low density lipoproteins and low high density lipoproteins, also patients with a history of high blood pressure, family history of cardiac disease, diabetes and smoking. All these risk factors will be taken into consideration with somebody presenting with chest pain. Also, any previous myocardial infarction or cardiac interventions would also increase the risk of acute coronary syndrome. So what investigations will be carried out? Well, probably the first thing to be done would be to take some blood tests to measure biomedical markers. Cardiac troponin T and I, these are very sensitive in patients where there's been necrosis of the myocardium. In patients with unstable angina, marginally high levels of troponin might indicate the high likelihood of a subsequent infarction, and these markers often stay elevated for up to 2 weeks. Creatine kinase MB was the standard marker for myocyte death. However, the problem with this is that it can be released by skeletal muscle and therefore not as specific as the troponins. There is some case studies whereby patients who have run marathons and have had a significant amount of skeletal muscle have presented at A&E with high levels of creatine kinase and have been treated for suspected myocardial infarction, when in fact it has been the breakdown of skeletal muscle due to the high endurance activity they've just completed. So not necessarily used now as much as the troponins. Can, however, be used to determine reinfarction, as levels should fall back to normal within 36 to 72 hours. Myoglobin can also be measured, and this is useful for rapid diagnosis as levels elevate very early, again present in skeletal muscle, and therefore has poor specificity. Other clinical investigations would be blood glucose. Patients with diabetes mellitus must be managed aggressively after myocardial infarction. And also we would look for a full blood count, as anemia may precipitate a myocardial infarction in a patient with angina. With regards to the other main diagnostic tests carried out other than looking at the bloods, then a 12-lead resting ECG is probably the main test in acute myocardial infarction. Classic ECG changes include ST segment elevation due to full thickness myocardial injury resulting from a rupture of a complicated plaque and complete occlusion. This elevation can appear within minutes and will almost always be present within 24 hours. You can see ST segment depression at the same time on the opposite side of the heart. So if we're looking at where the leads are, then on the anterior, if you've got an anterior occlusion, then it might, where you might get ST segment elevation on those leads, then on the leads on the opposite side you may see depression, so you'll get an opposite effect. Over 24 hours, ST elevation may resolve and T waves begin to evert, and we might see Q wave develop between 24 and 72 hours following MI. Pathological Q waves are signs of previous myocardial infarction and result from the absence of any electrical activity. If we have a look here with regards to these ST wave elevations and depression, ST segment is normally the flat isoelectric section of the ECG, and this normally represents the interval between ventricular depolarization and repolarization. ST elevation relates to a full thickness or transmural ischemia, and ST depression can include subendocardial ischemia or even infarction, but it's usually non-full thickness. So you see the three levels here. Normally ST segment is a straight line and is this period between depolarization and repolarization. Any shift in that is identifying problems with the electrical conductivity within the myocardium. If we look at this next slide, then what this gives you is the idea of the 12 leads and the ECG changes during the myocardial infarction. The anterior ST elevated myocardial infarction on the sort of the left anterior descending artery is probably carries the worst prognosis, usually due to the large infarct area in the heart. So often these anterior ST elevated myocardial infarctions are the ones with poor prognosis. You can also look then at the other ones and the damage to the septal wall, which again can cause ST segment elevation, and the others will give you some indication of what effect occlusion of certain arteries will result in on the ECG changes. So if we've had somebody appear with chest pain and the classic presenting symptoms, their ECG shows changes, whether that be ST elevation or depression, and their bloods show increased levels of the biomarkers, then we need to then think about what the acute management of myocardial infarction would be at that stage. So first thing is they will probably monitor oxygen saturation and administer if arterial saturation is less than 90%. If you look at the NICE guidelines, They suggest that you don't automatically administer oxygen, only if arterial saturation drops below 90%. They're often in quite a degree of pain and may often feel sick, and therefore often patients will be given diamorphine and an antiemetic to prevent that feeling of sickness. They will be given a single loading dose of aspirin. I think again the sign guidelines talk about 300 milligrams in a single dose. And this has been found in many studies and systematic reviews to reduce the mortality or improve the prognosis in ST-elevated myocardial infarction. It also, what aspirin does is an antiplatelet drug, and it inhibits inhibition of cyclooxygenase A and thromboxane A2. We also consider immediate access to reperfusion therapy, either percutaneous coronary intervention or fibrinolysis. NICE guidelines suggest offering angiography with follow-up PCI for patients presented within 12 hours of the onset of symptoms and can be delivered within 120 minutes of the time when fibrinolysis could have been given. If PCI is carried out, then low molecular weight heparin should also be offered. In ST segment elevation, is still evident 60 to 90 minutes after fibrinolysis, then that is suggestive of a failed reperfusion, and therefore some other consideration must be given. And I think it's important to note that NICE guideline CG167 gives you a clear guidance on the acute management. Contraindications to thrombolysis, then the absolute ones are hemorrhagic stroke or stroke of unknown origin at any time. So anybody who's had a stroke should not really be offered thrombolysis. Recent major trauma, surgery, head injuries within the preceding 3 weeks, again is an absolute contraindication, as is gastrointestinal bleeding within the last month and any known bleeding disorders. Relative contraindications, TIA in preceding 6 months, oral anticoagulant therapy, hypertension, advanced liver disease, and during pregnancy. Complications of MI. Arrhythmias due to the involvement of conduction tissue. In about 90% of patients who have an acute myocardial infarction develop some form of arrhythmia during or immediately after the event. And the incidence is much greater in ST-elevated myocardial infarction. There's also a chance of left ventricular failure due to the damage associated with the infarction. And if we think about the occlusion of the left descending artery, then that is a major cause of infarct on the ventricle and thus failure. There's also a chance of rupture. Ventricular septum defects occurring about 1 to 2% of failures are associated with the delayed or failed fibrolysis. You can also get a myocardial rupture because of the level of damage to the myocardium and aneurysmal dilatation. Also get valvular damage with mitral regurgitation, and we can also see acute pericarditis. Long-term complications, chronic left heart failure. Again, this will be determined by the how quickly we reperfuse the patient, and also of what artery has been affected will very much determine whether the patient develops left heart failure. Ventricular aneurysms are also a possible long-term complication, as is a recurrent myocardial infarction. There's also a chance of Dressler's syndrome occurring, which is a type of pericarditis. This is thought to be an immune system response after damage to the myocardium, and symptoms consist of fever, pericardial infusions, and pleuritic pain. From a long-term management point of view, then angiotensin-converting enzyme inhibitors are a mainstay of pharmacological management, as is dual antiplatelet therapy, so aspirin plus a second antiplatelet drug such as clopidogrel, a beta blocker, which will have the effect of blocking the beta adrenoreceptors and reducing the rate and force of contraction, and also a statin to try and control or to maintain a good cholesterol profile, reducing low density lipoproteins and with an attempt to increase high density lipoproteins. The other mainstay of management is lifestyle modifications, so increased physical activity, stop smoking. We know smoking is a risk factor for the development of atherosclerosis, as it damages the myocardium, as it damages the endothelial wall. Alcohol consumption within normal advised limits. Diet's important. We want to reduce the amount of saturated fats that our patients consume. Hopefully by doing that, we should control their weight as well, and again reduce any loading on the heart. So lifestyle is very important, and along with a comprehensive pharmacological intervention of the drugs that have been mentioned in the top of the slide. Okay, that finishes the lecture on myocardial infarction. It's certainly not, it covers all aspects, but I think what it does do is it identifies the key areas of concern and things to consider when examining your patients and considering surgical intervention. Thank you.